Hello and welcome to EconVersations. I'm Dan Sutter with the Johnson Center at Troy University, the host of the show. Alabama has been discussing and debating the expansion of the Medicaid program in recent months. Our guest tonight is an old friend of EconVersations, the former host of EconVersations, Dr. Scott Beaulier, the executive director of the Johnson Center here at Troy University. And he's here to talk about some of the history of the Medicaid program, as well as the current expansion and some of the possibilities for reforming the program. So, Scott, welcome back to the show.
Great to be on again. Yeah.
So tell us a little bit about the Medicaid program. When did it start and what exactly does it do?
So Medicaid is one of the Great Society programs from the 1960s. It was a program rolled out by Lyndon Baines Johnson, and it was intended to help the poor, and particularly the children of the poor, get access to medical care back in the 1960s. In 1970, the program took up just 0.5% of all income in the American economy. So it was 0.5% of GDP in 1970, and it was mainly focused on just really needy, impoverished children. Since 1970, we've had a real difficult time controlling costs of the program. States have also expanded coverage so that a lot more people can be granted Medicaid coverage, and eligibility guidelines have expanded. The types of treatments that are covered by Medicaid have expanded, and it's fueled a significant increase in the program's overall expenditures. Today, many economists regard it as one of the big three entitlement programs. They're Social Security, Medicare, and Medicaid, and they encompass the big three entitlement programs in the U.S.
So, and what exactly is an entitlement program compared to other types of programs?
Sure. An entitlement program is where you're essentially guaranteed coverage if you hit certain guidelines. So in the case of Social Security, it's if you're 65 or older, 62 or older, you've worked a certain number of years, you're guaranteed a certain payout. In the case of Medicaid, it's if your parents don't hit certain income criteria, and it varies across the states in terms of what those criteria are. You're guaranteed coverage until age 8, sometimes until age 18. In some states, if you're unemployed as an adult, you're guaranteed coverage as well. So it's the entitlement aspect of it is you're entitled to a certain set of benefits based on some other criteria.
So you mentioned the big three entitlement programs. We have a slide here. It's showing how exactly does Medicaid stack up relative to the other big two, Medicare and Social Security.
So I mentioned that in 1970 it was 0.5% of income. It's increased steadily to about 2% of all income in America is going into Medicaid right now. It looks, compared to the other two programs, Social Security and Medicare, it's not nearly as big. We spend about $430 billion per year on Medicaid, and that includes state spending and federal spending. So it's about $430 in the past year. That is a big number, $430 billion, but compared to Social Security and Medicare, it lags behind. The thing that really worries a lot of economists, including myself, is the likely rate of growth in Medicaid as we move forward. The pace of spending, even according to the Department of Health and Human Services, is supposed to be about 6.5% per year over the next 10 years. 6.5% increases in spending are pretty big, given the stagnant economy we all have been experiencing.
Well, we have some numbers here to sort of back this up, showing some projections, and by you see by 2040 is Medicaid is being projected by the Heritage Foundation here to double as a proportion of GDP. So it is actually, although it's smaller than the other two big entitlement programs, it seems to be on the worst trajectory.
It is, and if you think about that, that doubling is going to be, of course, way more than doubling because our economy will grow some by 2040. So it's a huge number. We'll be into the trillions in terms of total expenditures on Medicaid.
Now, Medicaid's a little different from Medicare in that we talk about states' roles in Medicaid, although it's also a federal program. So the structure of Medicaid is a little different. Could you explain that, please, for us?
So there's a couple of things that are strange about it. Social Security and Medicare are line items that you pay each month out of your tax. You can look at your check and you can see what's been taken out for Medicare and Social Security. Medicaid's a little bit different. It's based on matching grant formulas, and each state has its own match in terms of the amount that the federal government gives per dollar of state spending. So here in Alabama, every dollar that we spend, the federal government kicks in another $2 in matching funds. Some states that are more prosperous, it's not nearly as much. Florida, it's about 1-to-1 in Florida relative to 1-to-2 here in Alabama. So this raises all kinds of interesting dynamics for the program. When your state spends just $1 and they get $2 from the federal government, it encourages a lot of spending. It appears to be free money at times.
Right. Now, but then also states have a role in actually running this program compared to the Medicare program or Social Security.
So there is supposed to be a little more autonomy in terms of who is eligible, what your eligibility criteria are. There's some general features that all states must have because of the federal strings, but then there's a lot of variation. So in some states, as I mentioned before, non-working adults are given guaranteed coverage under their Medicaid plans. In Alabama, non-working adults must have really low incomes, just 11% of the federal poverty line. 11% of the federal poverty line is like a couple $1,000s to be eligible for Medicaid coverage here. So we have a less generous program than other states. So the principle of Medicaid is that there should be some variation across the states and allow a little bit of experimentation and coverage. The truth is that because of this matching grant approach, all states have this incentive to really load up on expenditures and eligibility.
And so part of the growth of Medicaid has been not just the overall health inflation, which we often hear about, that healthcare costs are rising so much faster than inflation overall, but some of it has been an expansion of these programs.
That's right. Yeah, so there's a whole set of benefits that are considered optional benefits. The states do not have to provide these benefits to Medicaid participants, but again and again states do it because if they spend a little bit of money, then they get more of the federal money. Here in Alabama, an optional benefit that is quite costly is just simple transportation to and from your appointments. So the state program and the federal government will cover your transportation to and from. So rather than having a family member get you to the University of Alabama Birmingham Hospital, if you take a cab and you're in Birmingham, you get reimbursed on that. This is something that is kind of questionable in terms of whether it's necessary and needed. You might say that, well, people have to get to their doctors, but it really adds a lot of expenses. But at some level, administrators say, oh, well, yeah, it adds expenses, but then we get $2 more for each of those dollars we spend.
Right. And there's another program that that was inaugurated more recently with the CHIPS program, or sometimes called S-CHIPS. And that's related or a part of Medicaid as well. So could you tell us a little bit about that program?
Sure. So you can think of this almost as like a sister program. With the CHIP program, it's Child Health Insurance Program or Plan. And what it's intended to do is help bridge the children who are in poor families who just miss out on eligibility under Medicaid. So a young child who maybe has parents who are just at the federal poverty line might not be eligible for Medicaid in some states. Not going to have good private insurance because his parents might be working in just a very, like a menial job or a part-time job. We want that child to have opportunity, and one way to assure that is good health. Right. And if they're missing out on Medicaid, missing out on private insurance, they're caught in between, and the CHIPs are intended to assure that those in-betweeners are covered. CHIP programs, of course, like Medicaid, have had major expansions, and they're also part of the matching grant approach as well.
And Medicaid is part of what we've seen as an increase in government's role in healthcare in our country. So this is just showing over the past 25 years, that would be, that the government share, this would be both state and federal, of overall healthcare spending has gone from about 1/3 to up to nearly a half. And so that. What does that mean for like the average resident here in the United States as government takes greater control over medical?
So it means a couple of things. One of the big ones is just greater congestion and clogging in the system. When you go for appointments, it takes longer to see doctors. When you're actually there, the doctors take a really long time to treat you because so much money is being poured into a system where supply is pretty tight. The number of new doctors being produced each year isn't growing by all that much, but the demand for these services is increasing thanks to expansions and programs, thanks to demographic changes like Medicare, where people are guaranteed coverage, but they're living a lot longer. So there's massive queuing in the system that's very difficult to alleviate. Another thing that we're seeing is all of this money going into healthcare, but health outcomes barely budging. It's not as though we're spending a lot more than we were in 1987 and getting just really great outcomes. In fact, the United States is not doing well, despite being one of the highest spenders in the world on healthcare.
And the Medicare, this is just emphasizing what we've seen before, that Medicaid spending has increased as a share of our total healthcare spending. And so this is the growth that you referred before. Now, if people want, if people want to say, well, we need to have some kind of health assistance for low-income individuals, a fiscal conservative might look at numbers like this and say, well, that's too large, but they'd just be opposed to that type of spending. But given the structure of Medicaid, there's actually a good reason to think that Medicaid is larger than any of us would like to see, and due to some of these institutional and financial arrangements you've mentioned. So how's that possible?
Yeah, well, it's the Medicaid mess can be understood as just a fundamental budgeting mess, or a fundamental mess of the federal government's overreach, and really setting up a program that doesn't make sense. It's a program that was intended in part to encourage federalism, experimentation across the states, but it does just the opposite. It encourages imitation of programs that manage to get a lot from the federal government. So one of the programs that's been very successful at getting a lot of money back from the federal government is New York. Okay, New York expanded lots and lots of coverage, and they've assured that the federal government contributes lots and lots of money back to New York. The kind of experimentation we get at the state level then is be like New York, as opposed to be an austere program that is providing good coverage for your citizens, but also acting responsibly in terms of federal outlays. Those kinds of programs lose out. So in the case of Alabama, if you're efficient with resources and need less money from the federal government, that extra money is probably just going to go to another state program. So you have this strong incentive, because of the federal match, to just use it and burn it, expand your programs. Otherwise, it just goes back to the commons that is federal money.
And so in Alabama, then a program in a specific part of Medicaid might only have to generate $1 worth of benefit for every $3 we spend with that federal matching formula. Now, you've done some research for the Mercatus Institute to look at some reform options, because with this out-of-control spending, this rapid growth in spending that we've seen in Medicaid, there is some efforts to try to go about and reform Medicaid. So what are some of the reforms that you looked at, and how do they offer a viable hope for containing Medicaid spending?
So this is complicated because a lot has changed, and I think we'll talk about the Affordable Care Act in a minute, but a lot has changed with the Affordable Care Act out there as a direction that a lot of healthcare is headed. But there was some significant experimentation in the late 1990s into the 2000s trying to get program costs under control, because states were looking at their balance sheet and saying, my gosh, healthcare is either the second or third largest item after K through 12 education in our state. What can we do about it? And they were trying to tackle their problems, their state problems, by getting Medicaid under control. Rhode Island is one of the more interesting cases. It's a small state, but they went about reforming in a way that is called block granting. They submitted a waiver to the federal government. They said, this is how we want our Medicaid funded. Instead of matching grant, we just want a block of money that we'll spend on health care. We'll assure that the poorest of the poor are given coverage, but if we act prudently with our money, we get to keep some of the difference. So it encouraged good stewardship of the money. It's one of the few successes that we have out there. And the consensus among economists on this issue, when it comes to how do we get a better rationing of health care, is block granting makes a lot of sense. It's one of the most important starting points for improving health outcomes. After that, a lot of things that make sense get down to encouraging market incentives and individual behavior. Not using emergency rooms, for example, through pricing.
So how would they have built in a market incentive
Sure.
here for something like this?
So right now, healthcare is very confusing for the average individual. You don't really know exactly where to go when you're sick or when you have a particular problem. And we all know in terms of the costs of coverage, an outpatient clinic or your own personal private doctor is much better than going to an emergency room. Mm-hmm. If you and I, on our own private insurance, were to make that decision, if we went to the emergency room, we'd have a tremendous copay that we would have to pay. Whereas if an individual on Medicaid goes to the emergency room for an illness, they don't have a copayment. So they don't know where to go, and when in doubt, go to the emergency room, which mm-hmm. is about 3 times as costly as going to an outpatient clinic. How can you encourage good behavior in that particular area? Introducing a small copayment for unnecessary emergency use seems like it makes a lot of sense. It unplugs or reduces the clog and congestion at the emergency room, and it assures that the patient actually gets better care. If an outpatient clinic is the appropriate place, why be waiting in the emergency room for 5 hours for the same treatment?
Right. And they can also probably help, because if you don't have a regular doctor to go to, a lot of times you're just getting treated for symptoms
yes.
in the emergency room as opposed to underlying conditions,
yeah.
right?
It's meatball medicine when you're at an emergency room. They're patching you up and not necessarily looking at your health history or a lot of the things that are important for long-term health outcomes.
Now, also you mentioned some health style or mm-hmm. lifestyle behaviors related to healthcare as well. So
yep.
what were some of those?
So these are interesting. West Virginia actually has a program where patients sign essentially a Bill of Rights or an agreement with the Medicaid providers, where if they engage in a certain set of healthy practices and see their doctor somewhat regularly, take their medications, hit certain health goals, they'll be rewarded with some money into a health savings account. Mm-hmm. That's something that makes a lot of sense in terms of encouraging healthy living. I wouldn't mind seeing that taken a lot farther and allowing money to be used for healthy activities like gym passes, gym memberships, and mm-hmm. And exercising. In a lot of cases, exercise is a really important investment to be making in yourself. We don't reward that, but instead we reward all of these things, which are the reactive measures after you've gotten sick or ill, and they're not nearly as effective in terms of rate of return. So
what were some of the other reforming states that you've looked at?
Yeah, so Rhode Island's the big one. The state of Washington is an interesting one. They moved ahead with a block grant mm-hmm. that was widely agreed upon by a Democratic governor, Democratic legislature. They didn't call it block granting, but it was, for all practical purposes, block granting. They were ready to roll it out, and the Affordable Care Act came, and they pulled it back. Mm-hmm. So what they've done instead is they've moved ahead with an embrace of a lot of the affordable care measures, and that's going to be their state Medicaid system instead. There are some states that did not do a good job as well that I looked at. Tennessee in particular is one that has just had a disastrous run. And what Tennessee tried to do was ram through what seem like and appear to be conservative principles with their system, but they didn't have buy-in from the legislature. Mm-hmm. They didn't have buy-in from interest groups, and they rolled out a program called TennCare that left hundreds of thousands of people confused, not insured, and it totally blew up and sent them about 10 years back in terms of where their program was at relative to where it could have been with a little more careful reform. One of the big lessons from looking at reform across the states is just the crucial need for buy-in across political lines and with key stakeholders to get any mm-hmm. kind of good reform. And so is there going to be any possibilities for reform in Alabama? Is Alabama a state that's going to be in need of reform of our Medicaid program, or how mm-hmm. do we stack up relative to some of the others? Well, we're at about 20% of our population is on Medicaid right now. Governor Bentley is not going to embrace the Medicaid Expansion, which is a feature of Obamacare. And if he were to do that, our enrollees on Medicaid would rise to 30%. So 1 in 3 citizens in Alabama could have easily been on Medicaid had he embraced the expansion. He's not going to do that. 20% is right around the national average in terms of dependents. Our program is pretty thin in terms of its expenditures, but it's one that's very confusing. We just rolled out a Medicaid expansion or a Medicaid reform that makes coverage regional. So now you're going to go to regional centers, and they've tried to carve up the state into different regions that are providing people with coverage and assuring that there's not waste. We don't want everyone rushing to UAB for coverage if you can get it done locally. Mm-hmm. The problem with this is that each of the regional directors doesn't have a real hard budget that's preventing them from going over. So if you go over in your region, you just ask for more money from the state, and it's not clear to me that it's going to check and constrain the ever-rising increase in Medicaid spending at the state level. Medicaid in Alabama has been rising rapidly. Part of that's due to the Great Recession. Part of it is just due to very generous benefits relative to private insurance and other alternatives. And the reform was inspired by the fact that we can't sustain the level of spending long term that we've engaged in already. The problem is it's pretty weak reform. It's just they've carved it up into regions and haven't done a lot else.
Okay. Well, you mentioned the Affordable Care Act, and this was the act that was passed in 2010. From a picture here from the signing. You see the president and the leaders of Congress and the vice president there. And although Obamacare and the Obamacare health exchanges are not part of Medicaid, Medicaid is related, or does have I guess a share of the plan under Obamacare. So what exactly is Medicaid's role envisioned as here?
It's really curious. So what Obamacare is using Medicaid for is to really expand and boost the number of people who are assured coverage. Approximately, so the original goal of Obamacare was to assure that everyone has coverage. They've taken down their goals so that now I think they're going to be happy if about 40% of the uninsured get coverage. Much of that 40% chunk is coming from the Medicaid expansion. States are given an option under Obamacare to embrace the Medicaid expansion, which means if they go ahead and expand coverage to mainly non-working adults who are at 138% or less of the federal poverty line, about $22,000 for a single individual. If they're at that income level or below, and the state chooses to move ahead with the expansion, they'll be entitled to a lot of federal money. So remember the federal match that I was talking about, where states spend $1 and then they get $2 from the federal government. For 3 years under Obamacare, you're guaranteed 100% payment by the federal government. There's not even a matching element to it. It's free money to a significant extent in the short run. This is irresistible for a lot of states. About 25 of them have embraced the expansion. And what you're doing is you're expanding eligibility. You're bringing hundreds of thousands, in some states millions of people, onto Medicaid, and you're addressing this issue of universal coverage. Now,
the thought of bringing some of these lower income individuals into an expanded Medicaid is to reduce the burden of employers having to provide health insurance?
That's the thinking, yeah. So health insurance in the private exchange market, especially when you're dealing with a very small number of employees, is quite expensive for an employer. We have all of these problems on the employer side already. Employers saying, gosh, I'm not going to provide insurance to my workers. I'm going to take the fine instead. I'm not going to hire a 50th worker so that I don't have to deal with Obamacare, the 49ers. You know, there's also the 29ers, which is keep your workers under a certain number of hours so that they aren't eligible for Obamacare. Lots of individual level behavior across firms saying we don't like this. One way to deal with it is to just expand coverage of an entitlement program and assure that some of them get caught. Yeah.
And Alabama is currently one of the states that has not yet decided to embrace the expansion of Medicaid.
That's right.
And it's been a very contentious issue within the state, hasn't it?
It has. So the governor has just basically rejected the expansion out of principle. We have a Republican legislature. I don't think that they'd be in favor of it either. But he's encountered a lot of criticism from the health industry, from hospitals, nurses, but also high-level political figures like David Bronner saying, in the short run, this is free money. You should be taking this money. It's $1.5 billion per year that could be coming into the state coffers to help get better health care off of the ground and also just provide some support at a time where budgets are pretty lean. I'm personally with the governor on this particular issue. I think that the long-term consequences of embracing an expansion are really hard to underestimate. I think that you could really get into some big problems taking the money, expanding coverage so that you increase your program from a 20% of your population to 30%, and then you're on the hook someday for all of those added expenses. And boy, that could cripple our state 5-10 years out.
But that would be at least after 3 years under the same matching formula that we have now.
That's right.
Perhaps an extra $500 million or a year would be the possible state cost in 3 years. So with the inflation, it would be higher than that.
That's right. Yeah.
Okay. But that's money that isn't going to end up being free, and this money only appears to be free,
Right.
and states are going to get themselves into budget situations, and then now all of a sudden a part of that comes online, right?
Yeah.
And they have to start paying for it.
That's right. So states are really good at spending money inefficiently, and when the money runs out, they'll either clamor to the federal government saying we need the free money longer, and free money from the federal government is being paid for by someone productive in California or Michigan or Illinois is paying for our expenditures here, and vice versa. It's just a big common pot in Washington, D.C. So it's not really free. And if they do taper and say no more money after 3 years and they hold the line on that, then all of the added expenditures are going to come from productive Alabamians to shore up the state funding side of it. And if it doesn't come in the form of higher taxes, it's going to come in the form of less services provided by the state elsewhere. So bigger potholes in the roads and less spending on education.
But nonetheless, in the short term, it is an attractive proposition to get extra money, and I'm sure everybody would attach some value to being able to provide health insurance to health coverage to people who currently don't have it. Right? So
that's right. It's really attractive, and we've seen some lawmakers who might be described as fiscal conservatives get wobbly on this issue. In Michigan, Rick Snyder's getting a lot of praise for attacking some of the collective bargaining elements in unions, but on the issue of the expansion, he's embraced it. He's a compassionate, soft conservative when it comes to health care. Same thing happened in Florida, where Governor Rick Scott got pretty wobbly on health care. And these are Republican governors who are considered responsible fiscal austerians, or people who are operating their budgets with significant restraint. But when it comes to visible health outcomes right now that are funded by someone else and other people's money, it's really, really hard to turn that down, especially when there's a lot of political pressure to do it. People, on average, view Medicaid as a good program, I think.
Well, thank you very much.
Thank you. Great to be back and have you hosting. Yeah.
Well, Scott, you'll be back next week.
I will.
I'll be talking next week. I'll be on to in the hot seat to discuss some of my research on one of the other former big entitlement programs, the welfare program and welfare reform. And Scott, you'll be back to ask some questions of me. Well, that's all we have for tonight. Thank you for watching, and tune in next week for another episode of EconVersations. Thank you.